Orsini from the New York State Newborn Screening Lab to talk about a recap of our newborn screening roundtable that happened yesterday.
Well, good morning, all. Thank you very much, Elisa, for sponsoring this conference. And yesterday's meeting is always really helpful, I think, for all the labs that are involved in the states taking on newborn screening. I think this year there were 4 new labs that came up onto screening, and we don't. They're fairly new at this, and hearing the problems they're going through, it reminds me of back in 2014 when I was sitting at a computer looking at this data. So I'm really happy that we get a chance to share what we learned and pass that information on. And we're going to talk a little about that on this talk today. So this is just a summary of the discussions from yesterday's roundtable, and it'll look fairly similar to previous years because we do talk a lot about the same things as we're trying to refine what we do. So this year there were 44 participants in this meeting, and not everybody was there, but people had provided some information or data on their state. So, and there's I may have counted that. I think that was the count I have. But there was a couple of we had the Netherlands, and I spelled it wrong. I can see now from here, and Puerto Rico, and joined in on the call, as well as Taiwan. So Taiwan's been at this for a while as well, and we're learning, seeing the same kinds of findings there as we are in the States. So this is over 7 years now. This ALD screening has been on the recommended uniform screening panel. It was February in 2016, and I think states have been adding it, and it was it's been slow, but kind of really coming up quick over the past 7 years to be at 35. This was not very long ago, 2018, just 2 states, and kind of see the history. I'm not going to go through these slides in detail, but it's just relatively rapid to 4 states in 2018. And you see we're just kind of exponentially increasing with each passing year. And I think this map isn't consistent with the other maps, but I found it, and it gives the dates. If anybody would like to see, it's hard to see the actual dates when each state started, but this is one I found on an ALD website. So yesterday when we were meeting, one of the things we always talk about is what incidence rates each state is having, what their screen positive rates are, any troubles they're having with screening. So where we really run into the problems with newborn screening for ALD is in the larger states where we're having to run a first tier analysis. And this first tier analysis is with flow injection mass spec. It turns out that that's not an accurate way to actually screen for ALD, and there's a really high false positive rate. And there's some technical reasons for that all of us talk about. And but one of the things is to get, when you're in the boat and you're looking at your data and you're looking at, well, this instrument shows data that's got a lot more positives than that instrument, or tomorrow I have a lot fewer than I did today. It's how do you deal with that? And that's some of the tricks of this, is how do we talk about how each of our states handle that. And a kind of a common way of dealing with it is to pick a percent of the highest specimens for that day. So if you ran 100 samples and there are 4 that are high, or 5 on that plate that are the highest, as long as everything else looks good, your controls look good on the plate, your blanks look good, then you just pick your 5 highest samples for that plate. But what happens when you start to go to 20 plates or 15 plates, or in states like Texas where you could have, I don't know, even more plates on a given day, and you got multiple instruments, and one instrument tells you one thing and another instrument tells you another, and it is a really tricky analysis, and it's hard for us to just tell the technicians and automate it and pick a way to do it when we try to scale up to that level. So there's a lot of extra work, and the labs really are persevering. I see all kinds of approaches to doing this. And we in some ways we're in there and we're talking about that saga, all of us big states. How do we deal with that? Because that's the hard. It's kind of a hard problem. There's no easy answer. But one of the things that we do know in screening is when we hit upon a baby that has clear ALD, those numbers really stand out. It's just that kind of in the borderline ranges where we get more nervous about it. So that's where cutoffs in the variance of unknown significance conversation always comes up as well. And so states that are small, the smaller states, they run a test where they get really good accuracy, and that's because they use liquid chromatography, which separates this interfering compound that us larger states have to deal with when we run flow injection mass spec. So not to get too technical, but that separation really turns what it does in as far as numbers is a typical baby has somewhere around 0.07 for a concentration of the compound we look for. Whereas when we run these flow injections, it can be 3, 4, 5 times, sometimes 6 times higher, and it's just falsely elevated. So the chromatography fixes that problem, but we don't want to miss anybody by not sending that sample to chromatography. So that's a large part of our kind of on the sidebar discussions. We can't really have solutions other than to run more samples by second tier. So what is this cutoffs and boost discussion? One of the things we noticed fairly early in New York is a state that has samples going back to 1999 in our archives, and Elisa was able to provide us with a list of babies that were diagnosed with ALD. Just to give you an idea of what numbers we saw on those, there were somewhere 0.8, 0.76, 0.8 kind of micromole concentrations, just to give you a ballpark number, which is a good almost 8-10 times higher than what we see in a baby that has no ALD and it's the population kind of result. But when New York first started screening, we also had a baby that we had a sample from an ALD patient that read at 0.48. And New York picked 0.4 as our cutoff for this first tier analysis. It sounded pretty safe because we don't want to miss anybody. And that's what newborn screening, the last thing we want to do is have a false negative in newborn screening. But so we detected within a month or two, maybe 3 months, a baby that was right at our cutoff, and then actually was right at our cutoff for second tier screening. So this was quite a bit lower than we had ever seen in our patients, but we only had 8 ALD patients, so we didn't want to, start off trusting just 8 results. So a lot of what we do in this consortium meeting is try to compare, well, what are we seeing that we know are true ALD cases from those that might be ALD cases, and then the ones that are clearly not ALD cases. And it's, unfortunately, it's not like always black and white. There's this gray zone, and the gray zone is where we typically see these variants of unknown significance. And people, the reason I'm talking about this a lot is this is what we spend most of our meeting talking about. So what is a variant of unknown significance? This is a genetic disorder, um, and what happens is there's a gene, it's called the ABCD1 gene, and if there's a variant in that gene that makes the membrane of a peroxisome be distorted in such a way that it can no longer do its function, I'm putting this in the best kind of terms I can for not all the scientist type people. If that doesn't do what it's supposed to and transport these very long chain fatty acids into the peroxisome appropriately, then those materials will build up in the body. And the compound we look for is C26, so it's 26 carbons long with this lysophosphatidylcholine group, and we refer to it as LPC just because it's a whole lot easier to say and certainly a lot easier to spell. So that builds up in the body, and one thing that we know with ALD is that that has to be elevated for a baby to develop ALD, or eventually a patient to develop ALD. The other problem with that is if you have very elevated very long chain fatty acids or this LPC compound, it's possible you'll get childhood disease, cerebral ALD. It's also possible you'll have adrenal function disorder, and those typically will go hand in hand for individuals with cerebral disease. But there are many people that will get just, it's called Addison's disease, where you'll get um, adrenal function, but you don't ever develop the cerebral form of disease. And then there's adult onset, which is adrenal myeloneuropathy, or AMN for short. That particular disease doesn't always affect people until they're very well into adulthood. And newborn screening is really meant to detect the cerebral cases and the adrenal cases, things that will happen in early childhood. And the AMN forms are a little less clear, but the marker concentration we talked about does not differentiate between which of those forms of disease will develop. So that there's a fair amount of monitoring now. I think you'll hear about this with MRI monitoring, looking at the brain and looking for any first signs of ALD, so that they can get these children with cerebral ALD, boys, can get a transplant. So far, what we see is those individuals with cerebral disease that are developing through screening, with very few, have very elevated marker concentrations like we've seen when we actually went back to our archive specimens and analyzed. Now, we're still seeing, though, these other babies that are in that middle zone, somewhere with not normal, but they have elevated marker, and it's not in anything we've seen in the ALD case that we've been able to analyze. But time is short. Even though we've been at this for 8 years, babies don't develop, and kind of the median age is somewhere between 5 and 7 years to develop cerebral disease. And a lot of states really just got started screening, so there's still a lot of data to collect. And that's the main reason. We're all thankful. I think the labs are thankful that Lisa Miranda organized this meeting for us, and we're having it once a quarter. So that's a lot of the history behind what we're doing. And I'll be a lot faster, but since I knew I had 45 minutes, I didn't want it to be done in 25. So I hope that painted a picture of what the problem is. And the boost, though, so what is a boost? A boost is anytime you find a variant in a gene that is and if you're a geneticist, I'm going to talk in geneticist terms for a minute. Not that I'm a geneticist, I'm an analytical chemist, but I get to play a geneticist nowadays. So I'm listening to people that know way more about this than me. But if a variant of unknown significance, according to the ACMG guidelines, the American Medical Genetics Guidelines, is a variant that's not really, we're not certain if it might be benign, not foreign-cause disease, maybe it will cause disease. We just don't know. But what we do know is the percentage of that variant is very low in the population. Because nowadays we're able to look at many hundreds of thousands of people, and we understand what variants are in the ABCD1 gene and what their percentages are. But it doesn't mean we know everything. And once you start screening, what happens is you pick up babies that have elevated markers, but they might be slightly elevated, but not elevated enough to cause disease because they have a variant in the ABCD1 gene that slows down the effect of the peroxisome and what the peroxisome is trying to do to metabolize these very long-chain fatty acids. Isn't bad enough to cause super elevated marker concentration. Well, how high can you be and still never develop disease? How do you ever find the answer to that question? You don't until you start doing newborn screening. And there's, we as newborn screeners do not want to raise that up or have that too low where we develop patients, the so-called patients in waiting. There's a public health perspective. I think a lot of people, right now with newborn screening being very, it's under the radar. False positives are something that really can harm newborn screening and public health. So we get protective of that just as much as clinicians and other people get protective of we don't want to have a family get missed. So there's there's a little bit of tension that gets in the room, and it's kind of like I always feel like Joe, the guy who wants to drive 100 miles an hour without a seatbelt. That's what I sound like when I talk about this. And I don't want to sound that way. I want to protect all the babies too, but I also don't want to have people endlessly in monitoring for basically their life. So how do we balance that? And ALD, I think, is not unique. There's Pompe disease, we've got Krabbe disease, cystic fibrosis. So all of these diseases, there's this middle ground. In fact, in cystic fibrosis, there's something called CRMS. It's a disease that nobody even knew about until newborn screening came about. And it's where you have something that's not normal, but you definitely don't have CF, but you might develop CF. And some of them do develop CF, but it hasn't been just long enough so we know how to differentiate. So I hope again, that's what we talk about. I mean, we were there for a good 3.5 hours, and we probably could have gone on this subject for quite a while. But one of the really good things is we have Dr. Stefan Kemp in our camp. Kemp's camp. Sorry I made that up. But he's been doing ALD for probably as long as anybody has actually studying the disease. And he's been really interested in the boost problem. And it turns out that he's got a lot of tools that help us define this. But what us as newborn screening group needs to do is collaborate. We're lucky we do collaborate. We're all in this and we want to learn, right? It's not like we're trying to hide things from each other. In fact, I think that's what makes newborn screening probably the best field to work in my opinion. Is like we work together. And Dr. Kemp's lab has the ability to look at variants of unknown significance and how cells metabolize with those variants in them, and then try to really decipher. Well, does it look like it's going to be able to the cell with a peroxisome that's got this defect is going to be able to perform the function or not? And between that hard data that they'll get, which doesn't always give a black and white answer, and newborn screening labs collaborating. So say we see a variant of unknown significance. How many times do we have to see it? What if we see it in every state, or we see it in a fair number of states, and we see it 50 times? And how long do we need to wait with patients to monitor them before we say that variant is benign, it's likely benign, or 100% certain it's benign? There's no magic answer for that. It's kind of like what interest rate's going to really help with inflation? Who knows? People make their best guesses. So, anyways, that's what we spent a lot of time on, and I hope I give you an idea. And then we continue to work together to solve that problem because we don't want to create patients and we don't want to miss patients, and above all, we don't want to miss patients. So I already talked about some of this flow injection analysis problems, and coming back to that, it's a technical problem. It's interesting. We're seeing some states that where their instruments are getting old and they're seeing their positive numbers tick up. New York just purchased 4 brand new instruments, and you think, oh great, this is going to make things better. Well, it didn't. It made it worse. So I felt like I was blasted back into 2014 when I'm staring at data again. Well, one of the nice things about these newer instruments, they have a lot of sensitivity over the old instruments, and there's a method out where we can change the ions we look for in the mass spec, and it's called negative mode, where this interferent no longer is present, causes problems. And we're starting to use that. It was first it's actually part of what's used in second-tier testing with chromatography, but now with the more sensitive instruments, you can do it without chromatography. And it's not great, not super sensitive signal, but it's a good way to monitor what your instrument's doing, and that's what we're finding. And I hope this is published by Dr. May Baker from the Wisconsin Newborn Screening Program, but nobody's actually running flow injection negative ion mass spec for live screening yet. And it's because mass spec sensitivity most people have isn't there. Our new mass specs in New York do have the ability to do this albeit it's just on the ragged edge. So we hope that though that will help really solve kind of this problem. Because I can tell you, I see samples that are 0.5, 0.6. But by the negative ion mode, they read 0.05, 0.06, more in line with a normal baby. And you see that long enough, and now you begin to get a feel for what is. One of the things I hope is we'll be able to maybe figure out what that interferent is. We know which samples seem to have the most of it, and we can pool. And if there's anybody that's got real serious mass spec skills, they might be able to, and they have the appropriate mass specs, we might be able to know what that is. But at least now we have a way of saying these samples really seem to have that interference in a bad way. So we're hoping that that'll help. So just another update here. I am 100%. I've been trying to do this ALD harmonization project for about 5-6 years. So the idea was that with that was to take a bunch of states and make it so we can compare apples to apples from one state to another state. And the CDC assisted us with this, and they provided a bunch of states with calibrators. We were able to look at those calibrators and understand. They still do this every year. Multiple times a year they'll send out these efficiency testing samples, but they also send out something they call QC samples. The QC samples are a way for us to kind of compare one lab to another lab, and then look at one of the things we want to do is look at our population screening averages for the second tier method, because that's what really kind of counts. And then where we're seeing true positive cases and where these borderline cases are falling, and be able to compare the labs in a way that if a new lab comes on, they can kind of see where they sit and what they might expect for a positive rate. So this project is for me to sit down and write the thing, but there's a lot of data that has come in, and the trouble with newborn screening data is every day you get new data, and it's like, where do you draw the line? I have to draw the line here soon, but a lot of it has to do with follow-up. Follow-up with ALD is another particularly tricky problem you may hear about. And that's, because what we found with babies that are born in a certain center, sometimes the family ends up going somewhere and we don't know where they went. We've been just talked about this problem in previous years, and there are some solutions, and some of the solutions that they go to a center that's a really strong center, and that's what happens. Some families will, they look up ALD and they find out where's the best place to be to get therapy, and they go to those places, and basically they say, see a newborn screening lab, and we're like, well, we help find you, and they go somewhere, and I don't blame people to go find the best place they can to get their baby's care. But now at least there's the method is that when they come to those centers, and hopefully this is actually happening, is they get consented to say, okay, as we find out more information about you, we're going to put it into a database that's in Minnesota, and if that data gets there, there's a release that Minnesota is now sending that data back to state labs. So if you're not part of that or don't know about that, that's something you should know about. The other thing for the states that are for anybody that's doing diagnostics, knowing about that would be really helpful, because we need that feedback, especially to ever solve the boost problem. And the more cases we know where there's been a clinically affected child, that adds to our data of here are the positives, here are the negatives, here are these things in the middle we don't know about. But if we start to get lots of numbers that are up here, we'll be feeling more and more better about what we're cutoffs on. So that's really the harmonization project, which links around really well with our quarterly consortium meetings. So here's some final numbers, just now that I've been rambling for a while. So looking at the state screening, this is the impressive part. Over 11 million newborns have been screened. We've detected 443 boys, 387 girls. The less impressive part, this was last year's information. I didn't get complete updates, and if anybody has updates on cerebral cases, but to my knowledge still, there's only two families treated for cerebral disease. Any other state wants to say, hey, we've got a patient and I forgot to tell you or whatever. But I know in New York we have two. California still doesn't have one. There are several with adrenal insufficiency that are popping up. The trouble with this is the endocrinologist will tell us is that just because you're on therapy for an adrenal function problem, it could be prophylactic. It does not mean that you could be on the edge of adrenal function that's hard to interpret, especially in a newborn. And Dr. Molly Riegelman may be explaining more about this in her talk. I think she's giving a talk, maybe not. I don't know. But anyway, she brought this up yesterday, and it's also true with other endocrine diseases like congenital hypothyroidism. A lot of people will, if you have a slightly abnormal result, provide thyroxine as therapy just to be sure, because it's better to be sure, right? And it's the same thing with adrenal function issues. To get the appropriate steroid treatment. So these we look at a little bit differently than somebody with cerebral disease, because that's really clear. Or if there's really clear adrenal disease, and that differentiating between those is really important for us, and we will screen, understand what we're detecting within the population. So for males, we have kind of the highest frequency states, just under 5,000 males that are turning positive. Low 168,000. Some big discrepancies here. A lot of that's because some of the states there's pending still numbers. That is their ALD call-outs, but we're awaiting a final diagnosis with a false positive, so we're not certain. Females range from 1,300 to 175,000. And overall, 1 in 5,000 and 1 in 26,000. So I'd like to remind people of kind of the incidence known prior to newborn screening was around 1 in 17 to 1 in 20,000. So we're in the ballpark. We've got to surround it. And there may be variables in these states that we don't know cause higher or lower variance. So why the variability? Again, early numbers for some states, different testing algorithms and cutoffs used, case definitions of ALD. So as a physician, in newborn screen, if the newborn screen comes out positive and the very long chain fatty acids comes out positive, you have to call that a positive ALD case. But if it's one of these very, very low ones, or depending on what lab it was tested, this diagnostic lab testing was done at, it's hard for us to be certain. So we have to be a little cautious about that. Like there's some clear ALD cases where there's an ABCD1 variant reported in numerous patients with cerebral disease, and it's well documented as a known disease-causing variant. And then there's others, like these variants that we're talking about, where we just don't know. And if they're in the borderline range, we have to be careful. We don't want to adjust our screening. Like if I had adjusted in New York our screening on that very first low one we had that was sort of normal to make it even lower, what happens when you do that is you just detect more people with the same problem. So you actually make it bigger. So if that makes any sense to people, the lower you go, the more you're going to find, and the more you're going to be questioned. So you kind of have to draw the line somewhere, and that's a really hard line to draw. Like, who helps you do that? So that's why we all get together again to emphasize that. So that's the story, anyways, for the variability. Other things are being detected through screening. We've seen this kind of grouping of disorders that have been picked up. So when you have very long chain fatty acid lysophosphatidylcholine elevated, it's not necessarily ALD. And this problem is interesting because say you have a variant in the ABCD1 gene that you've never seen before, and you have elevated very long chain fatty acids. It could be one of these other things that's circumstantially happening. So physicians do have to keep that in mind in the diagnostic and doing differential diagnosis. And I'm not sure that always happens. I'm pretty certain it does, to be honest. But there's ways to differentiate, but I'm not sure how clear they really are. So again, this is some stuff about the consortium. I think I went over this enough already, but we meet to discuss borderlines, meeting on a quarterly basis. For those states that are maybe less involved, I definitely would encourage you participating because this collaboration is really important for all of us to understand where we're going. So if you have an interest in that and you haven't been involved so far, either let the ALD Alliance or myself know and make sure you get invited. And that's the end of my talk. I don't know if that was 45 minutes. Hopefully it was close enough. But thank you. Are there any questions?
When you're reporting the cerebral cases, are you only counting it if it's the infant that has cerebral disease, or if a family member, so say baby's born, has an older brother that has cerebral disease? Do you have a way of capturing them?
Yeah, part of we do try to capture that. So that's the family history is a really important part of our process. So we have a table that we developed as a consortium group that basically looks at individual cases and said, one of the criteria is what's the family history? Is there, because if there's a family history of that, an older sibling or uncle or anybody that's developed disease through that may actually be discovered through the process. And this has happened through newborn screening. I'm sure it's no surprise that you're looking at a baby who's 2 weeks old, screen positive, and almost seems definitely to have ALD. That if they have a 5-year-old or 7-year-old brother or a cousin, maternal boy cousin, who are digging a little bit deeper into the family, discovers that there is somebody that has ALD. In that case, that variant now becomes really no longer a goose. It's not that in the ACMG guidelines terminology, it's not necessarily, it doesn't slam dunk it into pathogenic, but in our world of thinking, it does because you got somebody, especially someone who's non-symptomatic. Where it gets a little fishy is if it's a grandfather, maternal grandfather or something that has some kind of symptoms, because now it's a matter of I can. Is there any other possibility for explanation for what that grandfather may have? They may have the same variant in what looks like AMN, but if it's still an unknown variant, never seen before, but now in this grandfather, what's that mean? What's the grandfather's lysine phosphatidylcholine concentration? I don't know if that's usually measured, but trying to nail all that down is really a very important part of trying to get to the picture we're looking for. Because what if they have sort of a borderline number themselves that hasn't been really seen before? I can tell you with other diseases I've looked at really closely, beginning to wonder, it's everybody wants a diagnosis. Right? If somebody's not complaining and they're living their life, and now all of a sudden the baby's born and now they've got a diagnosis, it's not always so simple as that, especially with later onset disease. It's not that I'm belittling that or anything like that, but we look at that a little differently than we will somebody who has a cerebral disease in the family. That makes sense. So that's my long answer. Sorry. I've been thinking about this stuff for a long time now. Any other questions? Thank you very much for the opportunity to pass this info on.